that was simultaneously published in the New England Journal, as well as presented to a standing ovation. So just to get to the fun and exciting part first, Dr. Gwynn will share his thoughts here.
All right, thanks, Hannah. Can you all see my screen?
Yeah, it's in the right mode and everything.
Okay, excellent. All right, so as Hannah alluded to, I think we've known probably for the last several months that this was coming, that we had heard, at least preliminarily, that trastuzumab deruxtecan had significant improvement in progression-free and overall survival in this HER2 low. And so we're going to talk a little bit about this. So this is the Destiny-04 trial. Above is the title from the ASCO meeting where this was presented as a plenary session. And then down below is the same day publication in the New England Journal, also reporting this study. And so I think it's, as we were kind of briefly discussing at the beginning of the conversation today, it's briefly worth kind of understanding where we are in HER2 expression and what does that mean and how we should be defining that. And this is in evolution. And so, you know, traditionally how we thought of our HER2 positive cases are really breast cancers that overexpress the HER2 receptor and or the gene is amplified. And so these are pathologically IHC, immunohistochemistry 3+ or HER2 2+, but have amplification by in situ hybridization. And so that's how we sort of traditionally thought about it. And that was really molded around, those were the breast cancers that were responding to our traditional therapy initially with trastuzumab. Fast forward, and now we have this concept really sort of revolving around the data that we're seeing from this drug of a HER2 low population of breast cancer. And so we're thinking, at least in this trial, is defining this as HER2 1+, but this needs a lot more conversation, as well as HER2 2+, but not amplified. And so then if we kind of move to the left of the slide and think about, how does this fit in our current metastatic breast cancer paradigm? So in the middle column here, this was presented also by Dr. Modi. We sort of think of our three clinical pathologic subtypes of breast cancer that guide our management. So at the top, you have your HER2 traditionally positive, overexpressing amplified breast cancers. But below, in the vast majority, is your hormone receptor positive and your hormone receptor negative, HER2 negative are triple negative breast cancers. And so if you divide just on HER2, it's a small number that has been traditionally HER2 positive and a much larger population that is traditionally HER2 negative. But if we dive into those cases, we appreciate that quite a few of them, and we're probably looking at now, 50, 60% of these other non-traditional HER2 have some low-level expression of HER2. And so this is really going to have to revolutionize how we're thinking, how we're interacting with our pathology colleagues about thinking about HER2 expression, not just in our traditional HER2 positive, but in these sort of lower expressors as well. And so what has triggered some of this initial discussion was phase 1 and phase 2 studies. So one of them was the DAISY study. This is the phase 1b study that looked at trastuzumab deruxtecan, which is a antibody drug conjugate of essentially trastuzumab linked to this topoisomerase chemotherapy, and shows, again, this early study, an overall response rate of 38% in patients who have HER2 1+ or 2+ that we would not traditionally think of within that HER2 positive realm. And so that then led a lot more interest in developing trastuzumab deruxtecan in this kind of lower HER2 low space. So if we think about the drug itself, again, it's an anti-HER2 IgG1 monoclonal antibody that is essentially exactly like trastuzumab. It is then linked with a cleavable linker to this topoisomerase inhibitor. It's, as I've heard from others, when we think about these antibody drug conjugates, it's how much drug can we sort of stick on these antibodies to deliver directly to the tumor. But along with that, there's probably a lot of thought and benefit actually from the bystander effect. So though the antibody itself binds to the tumor, it's releasing this topoisomerase locally. And so you may have one breast cancer cell that is expressing HER2 that it is bound to, but then with the release of the topoisomerase, it is then spreading and actually affecting the non-HER2 expressing tumors that are in the neighborhood. So that's sort of some of the concept of how this may be providing benefit. So the Destiny-04 Breast 04 trial was an open label phase 3 multi-center international study that enrolled patients with this HER2 low, as we've sort of now talked about how we define that. Patients must have received at least 1 to 2 prior lines of chemotherapy in the metastatic setting. And patients who are hormone receptor positive must be considered refractory to endocrine therapy. And then enrolled patients were then randomized in a 2-to-1 fashion to receive trastuzumab deruxtecan or TDXD at the same dosing that we are using in our HER2 amplified or overexpressing at 5.4 milligrams per kilogram every 3 weeks, or treatment of physician choice. And so this was options of capecitabine, eribulin, gemcitabine, paclitaxel, and Abraxane. Primary endpoint was progression-free survival, and really was just looking at the hormone receptor positive population. Secondary endpoints were looking at PFS in all patients and looking at overall survival, again, specifically focusing on the hormone receptor positive, but also in the overall population. And we'll talk a little bit about kind of how that breaks down right here. So here are some of our baseline characteristics. Median age is around 56, 57 in both groups. The majority of patients seem to be coming from Europe, and Asia was sort of less from the US. The split between 1+ and 2+ is relatively even, but 1+ is a little bit more representative of this population. I think the difference, which I think may pose a challenge in the future, though, is the vast majority of these patients were hormone receptor positive. So 89%, almost 90% of these patients were hormone receptor positive, and thus the population of the triple negative is much lower, and I think may pose some challenges to thinking about how we can apply this there. And again, these patients also had produced fairly significant burden of metastatic disease, with the vast majority having liver mets. And so this is the progression-free survival report out. On the left is your hormone receptor positive, which again, showing that this study met its endpoint of improvement in progression-free survival with the TDXD arm having a over 10-month progression-free survival, whereas the treatment of physician choice was just under 6 months, with an absolute benefit or difference, excuse me, of just under 5 months between the two. When we look at the exploratory analysis of the triple negative, actually the difference between treatment of physician choice versus the TDXD arm is a little bit even more robust and to be a bit more impressive, but that must be taken in context of just fewer numbers. We're looking at around 40 patients versus 300+ in the hormone receptor positive. We look at overall survival, kind of seeing fairly similar numbers. Again, secondary endpoint with the hormone receptor positive, the TDXD close to 24 months of overall survival versus just over 17 months for treatment of physician choice, with again, statistically significant benefit of just over 6 months. But again, potentially a more robust benefit in the triple negative population. Again, this is an exploratory endpoint where 18 months for the TDXD arm versus 8 months in the treatment of physician choice. So then overall response rate was honestly, to me, also quite striking. I mean, there were several sort of aspects of this study that were pretty striking, but that we're seeing patients who progressed on at least 1, if not 2 chemotherapies, and we're seeing 50 or 56% objective response rate, and that's partial responses or complete responses in this population, vastly better than what we would see or what we're seeing with the treatment of physician choice, which is around 16%. So I think really sort of argues that this is therapy that can come in and provide potentially a meaningful benefit in half of the patients in a short fashion. Certainly within the context of all of this very promising clinical response, we also definitely have to be thinking about, well, how is this therapy tolerated? And so really no new significant side effects noted here. I think what we see more commonly than maybe appreciated is a significant amount of nausea, vomiting, and even comments that we need to be thinking of this as really more of a moderately emetogenic therapy, that being the trastuzumab deruxtecan. A lot of these therapies, as Hannah, you and I have discussed before, I mean, these are chemotherapy side effects. I mean, this is very much a chemotherapy. We see neutropenia, though much more so in the treatment of physician choice. We see the cytopenias as well. So though it is a directed therapy, we still see a lot of these challenges that we see with chemotherapy. Certainly the areas that we've also been very focused on in monitoring and watching these studies of trastuzumab deruxtecan have been the incidence of pneumonitis and ILD. So in the DESTINY-01 trial, there unfortunately were a couple of patients who had grade 5 and unfortunately died from ILD due to trastuzumab deruxtecan. In this study, again, there are 3 patients, less than 1%, but 3 patients who did have grade 5 ILD. I think ILD is becoming a lot more appreciated as a side effect, and I think in general folks are much more cognizant of monitoring for this and catching it early and intervening early. But at the end of the day, really the incidence of the ILD, it's much more common to see grade 1 and grade 2. That's really the vast majority of the ILD. But we have to appreciate that some of these folks very rarely can have a very serious outcome from that. Certainly, since trastuzumab deruxtecan is based on the trastuzumab molecule, effect on ejection fraction and left ventricular dysfunction has to be part of the conversation and analysis. What we see here is grade 1 and 2, primarily grade 2 changes with the TDXD arm, but really only 1 grade 3 and no grade 4 or 5. So I don't think we're really surprised to see these changes, but it again sort of adds another layer of things that we need to be thinking about when instituting these therapies in this non-kind of HER2 population. There are a number of other slides that I think are striking from this study, but I think I want to sort of also open it up briefly, maybe for some discussion on thoughts and future directions. I think what we're seeing now, this trastuzumab deruxtecan, I think will become the standard of care very shortly for hormone receptor positive. I worry that triple negative may lag based on the numbers, but we'll have to see. But I do think at some point, all metastatic breast cancer subtypes may be potential candidates for this therapy. And so it really changes the paradigm of how we think about this. We really need to think in depth, and there is ongoing sort of investigation about how do we define this HER2 low. And there are some studies in the discussion that were brought up looking at patients who had HER2 responses, but when you actually tested them by IHC, they were HER2 0, which would not have been candidates for this study. So that line between HER2 IHC of 0 to 1, I think our pathology colleagues can speak to this even more so. I think it's a very, unfortunately, a relatively subjective one, and something we really need to think about. How do we come up with methods to make this sort of more universal and consistent in evaluating this. And certainly, given these responses, thinking of how do we incorporate or think about TDXD and in studies that I think are now ongoing in the adjuvant setting and in the neoadjuvant setting, given these responses. Another sort of interesting spin is actually now we're seeing, and this was reported out also recently, that TDXD has some activity in HER2 mutant cancers. This is particularly in lung cancer, and that's, again, very small. It is a population that we see in breast cancer. So I think lots of information came from this. I think it will change a lot of how we think about incorporating HER2 agents. It will likely shape future ADC development, and definitely opening the doors for that and hormone receptor positive. So maybe I will kind of stop there and open it up, or we can turn it over to Corny or Tasha for their presentations.
Well, can you just talk about what we have as a trial here now?
So we have right now almost a sibling molecule where instead of HER2-directed therapy, it's HER3. And so HER2 and HER3 are similar receptors. They're all in the same family. We've known for a while that HER3 does appear to be a mechanism of resistance. And so Daiichi Sankyo has been developing not just trastuzumab deruxtecan, but other antibodies linked to deruxtecan. And so we have a HER3 linked to deruxtecan study that we are working with Sarah Canna in Tennessee on, that also is showing promise. And we have a report out from the phase 1 study showing significant improvement in progression-free survival, as well as a pretty good safety profile for that. So currently, that study is open at our center, and patients who are hormone receptor positive or triple negative are candidates for that therapy as well.
So this is big news and a real stunner, frankly. You know, and this is complicated. None of us have a perfectly good explanation. The discussant at ASCO and Will just did a really nice job of trying to explain how precision medicine is still happening, but it's very muddy right now. And I think it's great, but it's a little more toxic than we want. It's a little more non-specific than we understand. So, you know, really tricky. So I just have to ask Mark. So like if we have a patient with you know, a primary tumor that was in, you know, another country, and then came here, you know, NED, and then eventually developed metastatic disease, and then we treated her, and, you know, say we biopsied her liver, and all we did was fish on the liver. What do we do now?
I mean, that's a really good question. So I think that, you know, this group is real. I think there's a group with low levels of HER2 overexpression that responds to therapy. I think the problem we have right now, and this is what Kim's editorial was about, is that I don't think we have the right assay to find this group reliably, consistently, and then you know, put them in certain cohorts. So I'll give you an example. When we're looking at HER2 IHC, sometimes the background breast tissue has 1+ expression. And when we have those cases, we actually use that as our control to zero out the tumor. So we subtract out 1+ staining from the tumor.
Yeah.
You know what I mean? And so there's an inherent noise in the IHC that can happen just from pre-analytical variables, the titer stain on any day, et cetera. And so the differentiation between a 0 and a 1+ is it's not even really that it's subjective, it's just not reliable, I think, to call out that group for that sort of level of treatment at this point. That's just in my own opinion.
No, but I think you're right. I mean, this is just crazy.
So in fact, one of the reasons so to get back to your question, Hannah, one of the reasons we do FISH on metastatic sites is because we don't have background breast tissue, the metastatic site, to use as the control for the HER2 overexpression. And so, I don't know how to answer your question, Hannah. And I think it's interesting that, you know, we usually use FISH as a more definitive answer to HER2 overexpression, right? And this, we're almost going backwards in time and saying now, like, let's rely more on a less kind of objective marker. Like at least FISH has a count, right? Like people are counting numbers and there's an objective number to try to direct treatment in it. So again, I have no stake in this. I'm happy to try to do 0s and 1+, but I think that this group is totally real because clearly they're showing a response to therapy. I just don't think that we have the right assay right now and to actually like call out this group. I think that's the biggest.
And do you see any promising assays coming down the pipe? I mean, the discussant Dr. Larusso mentioned one or two, but I mean, how close would those be to actually be clinical practice versus sort of ongoing?
I mean, I think there stuff like that is a ways out, in part just because, you know, in medicine, it's so hard to move forward sometimes. I mean, when you get new assays, you know, and so even if you're able to show that there's better like molecular tests out there or better fish tests or something like that to try to quantify some of these things, getting the trials done, as you all know, to then show that that's true and then incorporate that. Like these, you know, the current ASCO 2018 guidelines for ER, PR, HER2 fish testing, those have evolved over like 20 plus years, looking at outcomes, trials, et cetera, to get where we are today. And it's kind of interesting because like it's taken so long to get here, and then it almost seems like we're just flipping around and just like,
exactly,
you know what I mean? Like the amount, and I don't
know, that's what's painful is it has taken us so long to get here, and there's been a lot of work. So that, you know, that Mark, the discussant, basically put up David Rim's work. The discussant was also from Yale, and said, this is the answer, which is like, I'm really glad Will didn't put that up, because we don't know if that's the answer. It might be.
Right.
Yeah. I think it's just really interesting. And I don't know if any of this comes from like, you know, COVID was a really interesting example, right? Where previous vaccine studies and stuff took forever to get these things out, right? And then they're actually able to show that you can move on this stuff pretty fast if you really need to. And I don't know if that's just made people think about, you know, maybe we shouldn't be taking 10, 20 plus years to move things forward at times. And that's kind of where some of this type of push is coming from and stuff. And I'm not saying I even disagree with that idea, but it's just, it is really interesting. And I don't know, I would say, you know, if we're gonna work with any of these trials and or offer treatment to 1+ patients, happy to work on that with folks. We would just want to know if you're going to do that, so we could reevaluate the case, like really think about that case if you're going to give treatment. Just because right now the difference between 0 and 1+, because they're both considered negative, is it's not like people are just throwing these out there. I don't want people to feel like that, but they're not.
Yeah, but it's trivial.
Not critiquing it to that level of like, because they know that right now currently that patient's not going to get treatment. So that a 0 and 1 is kind of like, they're not going to put a lot of time into that decision, but we would really think about it more if it was going to involve like treatment that could potentially have serious side effects and or, you know, cost a lot of money.
Yeah, no, this is so tricky. Thank you, Mark, for weighing in and
absolutely
letting us pick your brain here. All right, so I see that Tasha's here. So do you want to sort of quickly share your poster, Tasha, and then we'll get to Porny's longer presentation?
Sure. She said with her mouth full. All right.
I'm sorry.
Let me share. I don't have any slides. I just want to quickly go over the poster that we submitted. Except that I'm not sure that I have. Hold on just one second. I don't seem to be able to share quite yet because the Zoom, I have to reset my preferences somehow. I'm so sorry. It's not letting me share. Maybe Porny, do you want to?
Sure, I can go ahead and start, and then you can, if you have things that you can like chime in the middle and present your poster too.
For sure. Sorry about that.
All right. So do you guys see this okay? Let me just put it into. Can you guys see everything okay?
Yep.
Okay, great. So I just want to present a few of the abstracts from the oral discussion on early breast cancer, and you kind of see this as a theme. Is there's quite a bit of interest in integrating genomic information into clinical decision making. And so first I wanted to talk about the study that was really looking at de-escalation, the Lumina trial. This was a prospective trial looking at emitting radiation therapy after breast conservation in really just low risk patients. And so their main objective was to evaluate if RT could be emitted. And we know from the CalBridge 9343 trial that older women older than 70 can reasonably emit radiation as long as they're going through endocrine therapy. And so the Lumina trial sought to utilize both clinical and genomic factors to identify a similar population that's low enough risk that surgery and endocrine therapy could suffice at an acceptably low recurrence risk that they stated at 5 years of less than 5%. So again, this was a controlled prospective trial. They did have central Ki-67 testing. They had very specific cutoffs actually for Ki-67, ER, and PR, and this was based on some of the prior data that they had. And they had a pre-specified boundary for local recurrence, which was 5%. And so the Stein design included, standard eligibility criteria. And again, I'm pointing out that all the patients were actually ductal, grade 1 or 2, and the ER had to be greater than 1%, and the PR greater than 20%. And there was actually a discussion around whether the ER cutoff should have actually been higher, but it was noted that typically when the PR is greater than 20%, this actually correlates with a higher ER signature for a hormone-driven breast cancer. The study was actually conducted at 26 different Canadian centers, the sample size of 500, and the median follow-up was 5 years. And at that time, they had a local recurrence of 2.3%. And that's kind of seen here as well. And again, they did point out that the local recurrence of incidence was 2.3%, and it was still within the bounds of 90% confidence interval and did not surpass that pre-specified cutoff on either boundary. So I think, this is obviously a very thought-provoking study, and it really could impact as many as 30,000 women with breast cancer if kind of routinely used. I will point out, I think a couple of things that I noted was, the fact that they had essential Ki-67 testing, as with a lot of these studies that we're finding with, whether it's IHC or Ki-67, it's going to be harder to generalize to a larger population. And how are we actually going to implement this at the ground level? I think this, could be an option for low-risk patients where there's a contraindication to radiation or patient preferences. I think that, ongoing data, especially from the phase 3 DEBRA study that's also integrating, clinical information with genomic features, in this case, Oncotype score, might actually help to corroborate this finding and help us kind of move forward on how to integrate both of these features. So the next couple of studies I wanted to talk about were in the neoadjuvant space. The first one being KEYNOTE-522. So this is a sub-analysis. Obviously, most of us are fairly familiar with the KEYNOTE-522 regimen. This was, the double-blinded RCT that looked at neoadjuvant pembro in conjunction with chemo and early-stage high-risk triple-negative breast cancer. Of course, the primary analysis did show that chemo with pembrolizumab statistically improved both past-CR and event-free survival in these patients. And based on this, last July, the FDA approved this regimen for high-risk early-stage triple-negative breast cancer. This particular study actually wanted to evaluate the event-free survival by treatment arm within RCB categories. And so we know that, residual cancer burden actually has prognostic value with 0, 1, 2, and 3 corresponding with increasingly larger burdens of residual disease and worse prognosis. This was a pre-specified analysis that they had intended to do. So then, looking at their cohort, the prevalence of RCB in all patients in the KEYNOTE study, we can actually appreciate that the majority were RCB 0. And then among the patients that did have some degree of residual disease at surgery, there was a lower percentage of patients in each RCB category in the pembro groups compared to the placebo group, which to me indicates that the addition of pembro not just increased past-CR, but also just shifted the whole RCB spectrum to lower categories across the spectrum. And then, in this pre-specified analysis, we can see that an increased RCB score is associated with worse EFS, and that's independent of treatment group. And the addition of pembro resulted in fewer event-free survival events in 0, 1, and 2 RCB categories. Is actually most pronounced in RCB2. They noted that the RCB3, the benefit really wasn't seen as significantly, though this was a very small group, only just about 5% of the cohort. And then this table summarizes the event-free survival by the RCB category. And you can see that the most common event in both treatment arms is actually distant recurrence, which occurred in fewer patients in the pembrolizumab group. However, as the RCB category increased, the distant recurrence rates also increased, all the way up to 35%, even in the pembro group. And so this to us indicates that event-free survival benefit from pembro does extend to patients who don't achieve past CR, but there's still a large group of patients who have severe residual disease where, we still have a significant distant recurrence rates that we need to address and come up with more strategies for. So I think, the takeaways that from this study was that, past CR we know is clearly prognostic, and that KEYNOTE-522 provides us with an extra tool with immunotherapy to achieve higher past CR rates and shift patients across the RCB spectrum. I think the question still remains if we can use RCB in the clinical practice to further refine therapy strategies. So for instance, do all patients with RCB 0 and 1 really need adjuvant therapy, or just those with more residual disease? Are there other tools that we can use to help to stratify these patients? For example, ctDNA, I think has some promise. There was a study that was done by Dr. Schneider that evaluated patients who had residual disease after neoadjuvant and found that the circulating DNA positivity had a worse disease-free survival and overall survival. So perhaps the inclusion of both residual cancer burden and ctDNA can help us to, again, further refine the patients that do need the adjuvant therapy. I just froze for a second. Sorry. All right, and then finally, I think the other question that remains is that the need for adjuvant treatment. The question is, in this study they felt that the pembro benefit extends beyond adjuvant pembro. The benefit extends beyond the neoadjuvant setting, and potentially there's a benefit of the adjuvant pembro as well. And I think the SWOG S1418 that's been recently completed may help to answer this question as well in patients to determine if IO therapy is really necessary. The I-SPY2, so this was an additional analysis that was done. So the I-SPY2, again, is this ongoing adaptive multi-center phase 2 trial of neoadjuvant therapy for patients with early breast cancer with a primary endpoint of past CR. And we know that typically patients with hormone-positive HER2 disease, the rates of past CR are just low with neoadjuvant therapy, and many of these patients respond primarily to endocrine therapy. However, I think admittedly this is a heterogeneous group, and there may be a select group of patients who are sensitive to neoadjuvant therapy. So in this particular analysis, the investigators sought to utilize both clinical and molecular characteristics to better classify the hormone-positive, HER2-negative early-stage breast cancer to help them select the best strategies. So this diagram depicts the study design. And again, these patients had early-stage breast cancer with a tumor that was greater than 2.5 centimeters that were hormone positive. And again, if they were hormone positive, they did have to have a high MammaPrint score that was required to enroll in the study, and they underwent adaptive randomization to either control, which is paclitaxel, or one of 22 investigational agents since 2010. And then following that, they received AC as well. I think notably, this is a very biomarker-rich study, and so there's multiple points at which biospecimens were collected. And this analysis includes data from HER2-positive, HER2-negative disease patients that were enrolled in one of the 8 initial arms. So not all the investigational agents were analyzed in this, but one of them did include a checkpoint inhibitor as well, which I think will be pertinent to some of the findings. And so here we can see what the investigators evaluated from a clinical stage. They looked at a clinical perspective, they looked at stage and histology. And for molecular features, they looked at MammaPrint high risk score. They actually broke down MammaPrint high into 1 and 2. blueprint, which was defined as basal or luminal. And they also looked at this immune signature to further characterize the responsiveness to immune therapy. So in this particular cohort, about 38% or 379 patients actually had hormone positive HER2 negative breast cancer. And the diagram on the right here shows the past CR rates for this group. And you can see the overall past CR is about 17%, but it's up to high as 30% in the patients that received pembrolizumab. And so, looking at the past CRs for the clinical features, they're really as expected. The higher stage patients had lower rates of past CR, just about 10%. And, typically ductal patients had a better past CR response rate than your lobular or your mixed. Now, looking at the genomic factors, you can see here in the middle that in this cohort, the majority of patients were MP high, about 70% of them, and that actually correlated with mostly luminal subtype. And then the other smaller percentage of patients, about 28%, were this MP2, and that actually correlated. About 80% of those patients were considered basal subtype. And so we can see here that the PAT CR rates were actually much higher, about 3 times more likely to have a PAT CR if you had a mammoprint high 2 and mammoprint high 1, and luminal subtypes compared to the MP2 high. So, and I think you can kind of break it down here where you see this basal subtype in this mammoprint high 2, especially in the pembrolizumab, you can really appreciate what high PAT CR responses they had. They also looked at this immune signature, and again, the majority of the patients that were positive for this immune signature were basal subtype. And you can see here this especially was associated with, again, a higher PAT CR rate. And again, the pembro arm, 69% versus just 4% in patients that were immune positive with this PS signature. So I think the takeaway really is that we know that hormone positive HER2 negative breast cancer is a heterogeneous disease, and now we can define these molecular biomarkers using the mammoprint and basal signatures to understand who is more proliferative and who might have a better PAT CR and benefit from neoadjuvant chemotherapy. I think this SWOG 2206 study should be opening later this year, and that might also give us some additional information because that will be looking at high risk hormone positive breast cancers that have a high mammoprint subtype, and they're going to be randomized to actually neoadjuvant chemotherapy with or without durvalumab, and looking for a primary endpoint of invasive disease-free survival and PAT CR as well. So one of the other neoadjuvant abstracts that I wanted to talk to you about was the updated analysis looking at the CALBIDGE N741 cohort. This was actually probably the seminal phase 3 study that led to our use of dose-dense chemotherapy in early stage breast cancer. So the investigators wanted to kind of pool this population to further understand if genomic testing could actually correlate with endocrine sensitivity and then further define the population that required dose-dense chemo. So SET, which stands for sensitivity to endocrine therapy, is this genomic assay that was developed at MD Anderson, and its main purpose is to measure endocrine activity. And so it measures the transcriptional activity using genes that are involved in estrogen progesterone receptor signaling. And essentially a high SET score indicates higher endocrine sensitivity and the potential to derive greater benefits from adjuvant therapy versus a low SET score would presumably indicate endocrine resistance and potentially more response to chemotherapy. So the objective for this study, they had a couple of different objectives. When wondering whether a high SET score again was associated with a favorable disease-free survival. And they also wanted to compare SET with prior genomic biomarkers like the PAM50 and the RORT, which is includes the PAM50, but also includes 9-gene proliferation score that incorporates tumor size. And then lastly, they want to see whether the SET score could identify patients who would benefit from dose-dense chemotherapy. So they included the ER positive subset of patients where tissue banking information was available, and they used residual RNA, and they sent that to a CLIA lab, which ultimately yielded about 596 patients with genomic testing results. And largely the characteristics were fairly balanced, with the exception of tumor size and the receipt of a mastectomy. I think overall it's expected that patients who had a larger tumor in general probably had more biological data available. And this did actually comprise about 60% of the patients who ended up having a low SET score. So then let's turn our attention to the results. So, the findings show that the SET score is prognostic. I think what's most impressive here is that the data show that patients who have a SET score that's high seem to be very endocrine sensitive and had an improved disease-free survival and overall survival. However, the patients who are SET low appear to be endocrine resistant and had the poorer outcomes, as we would expect. And this is, again, both of these measures meet statistical significance. They did, again, look at to see how SET performs in comparison to other genomic profiling, such as RORT-PT, and they found that this, they use a multivariable Cox modeling, and they found essentially that this SET genomic score had better prognostic performance. And then finally, they wanted to know if this SET score could inform benefit from dose-dense chemo compared to conventional chemo. And really the answer to this question is yes. It seems that patients with a low SET score did have a significant improvement in their survival by adding dose-dense ACT. And this finding was actually noted in both pre and post-menopausal patients. So I think some takeaways from this is that we can see that SET is prognostic and predictive to chemotherapy, and that's actually different than other biomarkers that we've seen in the past. I think that we've already been routinely utilizing genomic assays like Oncotype and MammoPrint to see the benefit of additional chemotherapy, but I think I wonder if the future really is integrating an additional genomic assay like this SET tool to further stratify patients who would benefit from the dose-dense chemo, and perhaps even identify patients who perhaps are just endocrine resistant, more endocrine responsive, and perhaps would just need something like adjuvant abema if they're still high risk. I think that probably more prospective trials are needed before this becomes routine in our practice, but I think it is a very promising assay. And then finally, I just wanted to talk about one last abstract. This is from the ABCSG18 data. So, we all use aromatase inhibitors for our breast cancer patients, and unfortunately, these drugs can have negative side effects on bone health. And after much data, we've actually routinely now used adjuvant bisphosphonates for women in this setting, and it can not only improve their bone health but also breast cancer outcomes in postmenopausal women. And this particular study is looking at the long-term outcomes of adjuvant denosumab in breast cancer, fracture reduction and survival results. And this is kind of the updated analysis of that. And so just as a review, this was a prospective randomized placebo-controlled double-blinded trial that is started now 16 years ago. About 3,400 patients were recruited across 58 centers in Austria and Sweden. They had 6 different endpoints. Actually, the first 3 were actually shared in about 2015, and I'll show you the update from that. But this particular updated analysis, we're looking at specifically the survival outcomes. And so this is the prior findings back in 2015, and at this time they found that denosumab actually significantly reduced risk of fractures by actually about 50%. It halved them. It has a ratio of 0.5. Because of this, actually, interestingly, the the committees actually recommended to unblind. And so 16% of the trial patients did choose to unblind, about 250 crossed over. And as you can imagine, this does pose some challenges to the statistical modeling, and they did attempt to correct for this, but this, obviously could limit our interpretation of the results. However, the results that I'll share with you, and I think the main ITT ignores the crossover, so I think we can still extrapolate some information from the study. So again, I think the demographics, I think, were interesting to note because the majority were, lower risk, actually, node negative PT201 patients, ductal. And I think surprisingly, a majority of the patients did not undergo chemo, 75%. This is actually a little bit different than the group that we actually even think of using adjuvant bisphosphonates with, because in that meta-analysis, which did again show modest overall 2% survival benefit, these were actually higher risk patients in these trials, and about 83% of them did undergo chemo. So I think this is a little bit of a different patient population. And again, about half of them had some degree of bone loss at baseline. So then, in terms of the disease-free survival, we can see that it does improve disease-free survival by about 17%. And this translates to about a 4.5% absolute difference at 9-year follow-up. And again, this is based on the main ITT analysis, which did not include the crossover population, and it doesn't cross over 1, so some statistical significance there. When you look at bone metastasis-free survival and overall survival, the numerical benefit is similar, but you do have a crossover of 1, so it's not statistical significance. And then, finally, I think, what do we do with this information? I think it's one thing that I was hoping to, see more of was the safety data. They report that there's no new safety signals, no cases of ONJ, and there was only one case of an acute atypical femoral fracture. There was 3 treatment emergent deaths, but they didn't attribute to denosumab. The one thing that I didn't really find much information was about mention of vertebral compression fractures and rebound fractures, which we know that can occur with denosumab, especially with a missed dose. They did actually note that after stopping denosumab, part of the treatment benefit in the bone does go away. But again, because this is the abstract, I'll be curious to see what the publication shows and the supplementary data about some of this additional safety information. And then I think the other thing that could interpret or limit our interpretation of these limits is the fact that there was a crossover. They attempted to, do a couple of different statistical modeling, but again, the publication might provide us some more information on how robust this data is and how much we can, base our practice on this. I think that something to think about is that the DCARE trial, which was a similarly based trial with 4,500 patients, stage 2 and 3, postmenopausal, again, largely node positive, and actually underwent multiple systemic therapies, including chemo, so a slightly different population. In this population, they actually did not see a difference with the addition of denosumab, and there was 5% of patients who had ONJ. So I think when we see this publication, it would be important to know, what's the differences in these populations, and how, why is there a benefit that we're seeing here? So I think ultimately with this data, you could consider using adjuvant denosumab again, if as an alternative perhaps to bisphosphonates, but I'm not sure that I would switch add this to like a standard of care as of yet. So I think those are the slides that I had. I tried to skim through them here. What
I think, Porny, my concern is you might do harm there, because then when you stop the denosumab, they might lose bone density, and you've spent a lot of money. And this is, I think it's fascinating, and it just makes the whole topic difficult, but it doesn't add up yet. And so I don't think it's practice changing.
I don't think so either. I think it's still kind of not clear to me why the DCARE population, which was actually a higher risk population and probably more similar to where the adjuvant bisphosphonates have been approved, why this population would have a benefit in the lower risk population. So I think that's something that's a little bit perplexing, and I'm wondering if some of that is because of the crossover or whatnot, but it'd be interesting to see. But I think it's an interesting finding in the study, but more really has to be done to understand, why there's discrepancies between similar studies.
Yeah, so while Tasha's getting her slides up, let me just ask you one more question. Megan noted that in the Lumina trial, whether she wants to know whether the rate of endocrine adherence was presented, and I couldn't find it in either the slides or the discussant.
They talked about it briefly with the discussant, and I'm trying to recall the context, but I think it was around 80%, but I'd have to go back to the discussant panel questioning.
Yeah, I quickly looked at Jennifer, it's Jen Bellin was the discussant, and I looked at her slides and I didn't see it in there.
It was actually a question, a panel question that they asked about. So yeah, I think, when more data is out, that would be a very important question to ask, because, that's that's kind of our premise when we don't offer radiation to our patients older than 70, is the hope that they'll get the full endocrine therapy at least.
Right, and the problem is that many don't, for a variety of reasons, and so it's just a known difficult thing. However, the good news is it's a kind of a prognostic issue, not just a predictive issue. So I think it's still exciting. All right.
Yeah, I think it is.
Tasha.
Sorry, this is Megan. I just was going to say it's just their data is so short term too, that if they had 80% adherence, which I think is pretty high, what happens when they stop taking their endocrine therapy?
Right.
They probably will.
The follow-up is so short on this study.
Yeah.
Yeah, no, I mean, Megan, I would love to know, just for us sometime, what we think our adherence rates are, and if there's some way in, the EPIC landscape that we can actually know what our adherence rates really are. Because I think, this is just a known problem in breast cancer, is that adherence rates are really low to endocrine therapy recommendations. And, Don Hirschman's made a career of this, and it still is really something that's difficult for us to deal with and for us to take into consideration. And when you're trying to have the discussion with somebody about, should we do radiation or endocrine or both, you're making an assumption that they're going to take 5 years of endocrine therapy.
Right, exactly.
All right, Tasha.
All right, sorry for that little glitch. Thanks for taking over, Porny. So we had a poster that we presented at ASCO looking at matched FES and FDG PET imaging in patients with what we could normally call triple positive, although I guess some of these patients were PR negative, but it's estrogen receptor positive and HER2 positive advanced breast cancer. So as you, I'm sure, are aware, the FDA has recently approved FES PET to look at patients with metastatic ER positive breast cancer. Our institution has played a prominent role in that. But it's not clear what to do with patients who have HER2 positive disease as well as being hormone receptor positive. So those patients have normally thought to be driven, their disease is thought to be driven primarily by the HER2 pathway. But it's clear, I think, that the estrogen pathway does, there's crosstalk between those pathways and does play a role. And so we have this database that we have maintained since 1996 of patients with estrogen receptor positive breast cancer and a handful with HER2 positive breast cancer. And so we took a look at the database to look at how many patients we actually have who have scans and who have serial scans who meet those criteria, and to see what we're finding. Number one, is there activity in these patients who were treated with HER2-directed therapy? Is there a hormone or estrogen activity in those patients, and is it comparable to the other patients that we're seeing? We didn't answer that question specifically within the scope of this poster, but we did look at the scans themselves to see how active they were. And then we also identified 36 patients who had ER positive, HER2 positive breast cancer. And we also identified 8 patients who had actually had serial scans. So as they got treated, we scanned them over time. So they had anywhere between 1 and 4 scans over the course of, in some cases, several years. And so ultimately we saw that the ER pathway was quite active in these patients. And indeed in the serial scans, we found that interestingly, FES generally, so the avidity of FES generally increased with treatment, and treatment generally is going to include a HER2-directed agent, even as in the FDG scans, it in many cases decreased over time over the course of at least 2 scans. So obviously these are small numbers and it's hypothesis generating, but I think it is interesting both to notice that that this pathway is active in these patients, and it's an opportunity to explore further to try to identify perhaps a cohort of patients who might benefit from we don't say de-escalated regimen anymore, an optimized regimen that is not, that doesn't employ so much upfront aggressive chemotherapy. So a possible possibly less aggressive regimen for these patients that could be less toxic and still be as effective. So questions, thoughts? All right. I think that Hannah had to dash because she's heading down to Harborview. I don't know, Hannah, if you are interested in making any comments regarding this. All right. I think we'll wrap up. I'm going to stop sharing. We'll wrap up here. There are obviously other studies to talk about ASCO, from ASCO, and I think we can do that at a future meeting. But in the meantime, I think we're running out of time. If there's any other final comments or questions, otherwise we will wrap up. All right, thanks everybody.